So first of all, it's great to be invited to give this talk on an intervention that we did. There's a screen here. Patient-tailored reminders, which we found to be, and we'll see if you agree, an effective pragmatic adherence intervention for primary care. The names of my colleagues are on this slide, of which there are respiratory specialists, a GP, and 2 psychologists, actually. And it's really important to have a GP on board when you're doing a study in primary care. Really crucial. So, as all of you here know, I'm sure, in asthma, daily inhaled corticosteroids are prescribed with the aim of achieving asthma control through prevention of symptoms and exacerbations. But poor adherence, as we've heard multiple times today, is common with inhaled corticosteroids. Just a couple of figures here. In Australia in 2009, actually 9 to 21% of patients had ICS dispensed at a level consistent with regular use. And just for comparison, in a USA managed care organization, mean adherence was around 26% with ICS. Poor adherence is associated with poorer asthma outcomes, for example, reduced quality of life, greater risk of exacerbations and mortality. And another figure, we've seen some figures today, but close to 39,000 Australians were hospitalized due to asthma in 2011-12. So guidelines emphasize the management of adherence in primary care, but there actually are no tools existing for GPs or nurses to use to tackle adherence, and it can be a bit of a thorny topic. I mean, how do you go about having a conversation about adherence? Poor adherence can be described as intentional or unintentional, and some of you may have heard about this sort of dichotomy before, the idea being that intentional adherence would be about the attitudes or beliefs of the patient who's prescribed the medication, and unintentional could be things like inhaler technique, for example, or simply forgetting or poor planning. So 2 overarching interventions could tackle poor adherence with inhaled corticosteroids. To start with, an empathic, tailored communication, really tailored to the needs of the patient, could help achieve better adherence. And we know from the literature that the odds of good patient adherence are 1.62 times higher in patients of physicians who've been trained in effective communication. Motivational interviewing is one such approach. And it's been used successfully in quite a brief form, which is a one-off hit of communication and quite short training in the GP for improving adherence with medication and smoking cessation. So what about forgetting or unintentional poor adherence? Well, there's some evidence, still quite small, but growing evidence that providing reminders and feedback for inhaled corticosteroid, for medication, can increase adherence. And there's only, at the time we started this study, there was only one published, which was a randomized control trial in asthma, comparing inhaler reminders and feedback with a control group. And you can see there from the figures of 93% and 74%, these figures are quite high, even in the control group. So it's quite a research example, you might say, and may not represent what you'd find in real life. So the aims of our study were to evaluate the effectiveness of a feasible GP-delivered adherence intervention for primary care to improve adherence and asthma control. I don't want to bamboozle you with methodology, but I'll explain more about this later. But we used a 2x2 factorial cluster parallel group, RCT. You shouldn't say that when you're drunk, by the way, it's pretty hard, with 6-month follow-up. So each patient was in the study for 6 months. What it means is that individual GPs were randomized to one of the intervention groups, and they enrolled their patients into the study, and those patients formed a cluster. I'll show you more about the design shortly. So the GPs enrolled up to 7 of their own patients. These patients had to have poor asthma control as defined by the asthma score or the asthma control test, whichever term you prefer, and they had to have been prescribed combination therapy for at least a month. GPs followed up the patients at a second visit, ideally 28 days later. In reality, it was more like day 57. GPs were reimbursed for their participation in the study. Now, the study staff, to keep this as real life as possible, the study staff collected data by telephone or postal questionnaires and never actually met the participants. So this is really a GP-led intervention in the primary care setting, in real-life primary care. And this hasn't been done before for inhaler reminders. So for those that are interested in this, we did analysis by intention to treat. We used mixed models adjusted for baseline, scores, GP clustering, and repeated measures. And you have to adjust for GP cluster because of the design. Okay. So these are the 4 different intervention groups. So the first group was active usual care, and this aligned with Medicare cycle of care in that GPs provided to their patients a written asthma action plan, personalized to the patient, and also checked their inhaler technique. Now, the second intervention was to tackle the beliefs. Remember, we talked about beliefs and forgetting. So to tackle the beliefs part of the issue, you might say, we developed an intervention called personalized adherence discussions, and I'll tell you more about that shortly. And this group of GPs also delivered active usual care. Now, the third group the third intervention is the one that tackled forgetting. And I'll tell you more about this shortly too. This was inhaler reminders and adherence feedback, and also usual care. Now, the fourth group, they got both. So they got the beliefs and the forgetting interventions. This is a really robust design. It allows you to see, does the belief intervention work on its own? Does the forgetting intervention work on its own? If you combine them, do you get a synergistic effect? Now, you might intuitively think that would be the case. If you just remind someone, but you don't talk to them about their asthma and the issues that they're having, will that work on its own, and will there be a difference? So just telling you about the beliefs intervention, the personalized adherence discussion. GPs in this group received 2 hours of training in brief motivational interviewing and also goal setting. And they used a goals card, which is quite formalized, to help guide them through that process, which I haven't got time to tell you about today. But they also received a toolkit to guide them through this process, because GPs, as we know, are great communicators, but they may not be used to this form of empathic communication. So we produced a lot of tools to help guide them through the kind of language you might use to use that style of communication. In the toolkit, there was a 10-item questionnaire which quickly identified the key barrier that particular patient had with intake, that prevented them from taking inhaled corticosteroids. I'll show you the questionnaire. And also, after responding to that questionnaire, the GP could use a relevant information sheet to discuss those particular barriers in a really accepting way. So not you should be taking your medication, but let's talk about the reasons why you're not. So this is the questionnaire. I won't read it out, but you can see it's completed in the usual way with the Likert scale, and this was developed based on previous study, and these are the most dominant or predominant barriers to using inhaled corticosteroids. The GP then could put a template on the top like this, and you can see the ticks at the bottom. I think I've got a laser pointer here. Yeah. So the black parts blocked out the bits that weren't important, and the colored parts told you what the topic was, and these are the different barriers, and which was the strongest response. And that could either be on the left or the right. So in this case, this patient shows the strongest response to the color of aqua, and it's, that particular topic was, I don't take it, or it was around adherence. So that meant the GP knew right away that they could possibly be having a conversation around adherence, because that was the clearest barrier. So these are the guides, and again, I won't go through them, but you can see that they're also color-coded, which meant that, again, the GP could easily pick out the correct information sheet, and they weren't giving information that wasn't relevant to the patient. And they could use that to guide an empathic discussion about the particular barriers. And we pilot tested this with GPs and also asthma patients using inhaled corticosteroids. And that was a very interesting process, because I think as healthcare professionals, we tend to add a lot of complex words, and it's really important to have patients tell you that actually this makes more sense to me. So we removed any difficult words in there and made it more lay and very simple information. Actually, during the piloting, it was suggested to us that we needed a blank sheet, because although we might think we're the authority on what are the barriers to use of inhaled corticosteroids, everyone's different. So that made perfect sense. So we included a blank sheet, so anything could be on the table, any topic could be discussed as well. So now we're coming on to the inhaler reminder and adherence feedback intervention, the forgetting intervention. So patients of the reminder group GPs had a smart track, or we called it an asthma track in the study, and it was clipped onto the patient's inhaled corticosteroid. And this device provided twice daily personalized inhaler reminders for missed doses. And personalized means the time of day. And you could change the times for the weekend. I'm going to play you a couple of ringtones if it works. This is one of them. I won't dance. Here's another one. Very Australian. It's my favorite. Of course, we also had classical music and some nice, gentle ones as well. So there were 14 different ringtones that patients could choose from. They could actually change the reminder times and tones themselves. They could cancel. They could completely stop the reminders. And we had quite a debate about that when we were designing the study and what would actually happen with that. But it was really essential, I think, to have that there so the patient could say, I've had enough of this, and stop it rather than throwing it in the bin if they got really sick of it. The device, you can see, they also provided on-screen adherence feedback. So you can see there it says last taken 1 second ago, and it counted up. So if they'd taken it a week ago, it would say last taken a week ago, and so forth. Also, they could log in to a website. The actual device uploaded the data to this secure website. And this graph shows how many puffs the patient had taken each day. And the patients and GPs discussed that at the follow-up visit, but the patients could log in anytime and take a look at that. I mean, nowadays you'd put it on a phone. It would be a lot simpler, but around then it was websites still. So all patients had a covert version of this device without going into the detail. This just allowed us to collect adherence data for all the groups, even if they weren't in the reminder group, and to sort of cover what the device did, it asked them questions about their asthma once a month. Okay, so here are the results. So these are patient demographics and baseline characteristics. You can see here that there were 143 participants enrolled in the study. 62% of them were female. Their mean age was 40 years. And their asthma control test at study entry was 14.6. And we wanted to enroll patients with a score of 19 or less, which is poorly controlled asthma according to the asthma control test. The other things I wanted to point out that the participants had high doses of inhaled corticosteroids at baseline in all groups. In fact, this is fluticasone equivalent, these figures. You've got 683 micrograms daily and so forth. You can read the rest for yourself. The average was 718. And 500 micrograms would really probably be maximum efficacy for fluticasone. So these are a bit higher, but not uncommon in a community population like this. The other thing to point out is that participants were from diverse social and linguistic backgrounds, with 51% living in a socially disadvantaged area and 37% speaking a language other than English at home. And that's important for the representativeness, of course, of the sample. So now we come on to the results about adherence. I'm going to use my laser pointer now so I can tell you what all the colors mean. Along the bottom, you've got the groups, and these are abbreviated. So you've got your usual care, personalized adherence discussions to tackle the beliefs, inhaler reminders and feedback, and the combination of the two. So what you can see, I should tell you here that this is the percentage prescribed dose, the mean per day. So this is the average mean per day. So over 6 months, adherence was significantly higher in the reminder and feedback groups, those are the ones in red and blue, than in the non-reminder groups, which included the personalized adherence discussion and usual care. But there was no difference between the usual care and the personalized adherence discussion group, and no interactive effect, which is what we were expecting to find, that if you had a reminder, but also a conversation about your personal barriers, that would have an interactive effect. Now, this is the same data, but looked at it a different way. This is basically showing the adherence pattern, if you like, over time in the participants. So you can see the same colors. You've got the inhaler reminders and feedback in red, inhaler reminders and feedback plus discussion in blue, the personalized discussion alone in green, and usual care. And this is the trajectory from 1 to 6 months, because obviously it took a month to collect the first set of data. So you can see that there's a downward trend, and at this point you're going, oh, maybe that's not so good. So a couple of things to point out. By month, mean adherence was consistently and significantly higher in the reminder group, in the red and in the reminder groups, the red and the blue ones, than in the non-reminder groups. And that was sustained throughout the study. And if you look at the difference at 6 months, in the reminder groups, the mean adherence was 60%, the average, I should say, and in the non-reminder groups, only 29%. So regarding this downward trajectory, if I go on, yeah, I should point this out as well, that figure in the usual care group of 26% is really similar to the one I showed you earlier, of the rate of adherence in a typical population. So basically the usual care group had dropped to that standard adherence in the community. So I wanted to show you this as a comparative trajectory because this also uses electronic monitoring, which is the method we've used in our study. And this shows mean adherence and the trajectory of how it falls a week after hospital discharge. So what you can see here is that within 7 days after hospitalization and then at discharge, that the use of inhaled corticosteroids has dropped to 50%. So to actually maintain the adherence at the levels we did for 6 months is actually quite important, even though the rate looks a bit depressing in one respect. So now looking at the asthma control test. So this is about asthma control. Did these interventions improve asthma control? So asthma control improved in all groups, and you can see it really jumped up at 2 months. And the change was more than the minimal clinically important difference. But there was no difference between the groups. When I looked at the patterns, I thought it was really interesting that the PAD groups, so the ones in the blue and the green, these are the ones that had the adherence discussion, that their asthma control continued to improve between 2 and 6 months. And maybe that says something about sustaining behavior change. We might talk about that shortly. So the other result was the proportion of patients with exacerbations over 6 months by intervention group. So you can see in the non-reminder groups in the non-reminder group, 28% of participants had an exacerbation, one or more exacerbation, and in the reminder group, only 11%. So in primary care, reminder and feedback produced significantly greater inhaled corticosteroid adherence above active usual care, and that was sustained at 6 months. Personalized adherence discussions actually produced similar adherence to, and I should say active usual care, because these participants were given an asthma action plan and an inhaler technique check. GPs responded really well to the communication training, and I'm kind of wondering, looking at the trajectory, if a longer study period was needed. But it's also true that such a short training period for GPs may have meant that the communication skills were poorly maintained, and GPs were blinded at study entry. They actually didn't know what the study was going to be about entirely. They didn't know they were getting communication trainings. They may not have been interested in the process, and that's important to mention. So it looks like there was an unclear relationship here between adherence and asthma control, because asthma control improved in all groups despite the intervention that was delivered. But there was a high baseline dose of inhaled corticosteroids, and perhaps that masked the effects of increased adherence. But fewer patients in the reminder and feedback group had exacerbations during the study. So it might be that poor adherence maintains reasonable symptom control, but leaves patients vulnerable to exacerbations. I don't know how I'm doing for time, because I'm well through it. So just 5? Perfect. So there's a new study that's just come out of New Zealand, actually, which corroborates our findings in kids. This wasn't a primary care-based study. It was, again, a randomized controlled trial. But it's for 6 months in 220 kids. And the median adherence in the reminder and feedback group was 84%, and in the control, 30%. Asthma control was significantly increased in the reminder group, or was significantly better in the reminder group than the control. And exacerbations were significantly lower, also in the inhale reminder group. So this seems to be a really effective intervention. So this is the first study in primary care of this kind of technology, and it's actually quite an easy intervention for a busy GP or nurse to deliver, because you hand over a device and off you go, I suppose. No burden. But further work is needed in the field to understand this sort of complex relationship between improved adherence and asthma outcomes. And also, implementation. You know, is this really viable to implement broadly throughout Australia or internationally? And also in different healthcare professions. It'd be really interesting to look at this in nurses or even in pharmacists. So I thought if there was time, I might show you some ongoing qualitative work that we've done as part of this. Really, we want to understand the barriers of facilitators to trying to implement these interventions, and also explore if there really is any interaction between communication and reminders that maybe wasn't detectable at the group level, because you can well imagine, depending on what your barriers might be, the communication may be more or less important. So I'm just going to briefly show you this. This is very early data, but just interesting to show you. So is reminding alone enough? So this is what patients, these are 1-hour interviews, 10 participants in each of the groups, and I'm just talking about the participants in the reminders alone or the reminders plus personalized adherence discussion. So in the reminders alone group, participants described that the intervention lacked discussion about preventer use or about their concerns about preventer use. So these participants saying things like, it was no real advice, to be honest. It was just sort of take the preventer and see how you go type of thing. And I was also hesitant to take my preventer because I don't know if it's necessarily good to be taking medication all the time. Now, on the other hand, in the Reminders Plus discussion group, participants described the importance of inclusion of that kind of discussion. Being reassured these facts, because I'm always best on facts, talking to my GP to convince me that long-term use of these preventers will not have any long-term side effects on my lungs, ovaries, whatever. So I had a philosophical change of mind about using my preventer. And this is a really interesting, this is a Bryony who was just, she had a massive change. She went from hating, as she said, steroids, to actually being adherent to her medication. So just one more slide and then I'm done. So could the reminder plus discussion be better at sustaining change in adherence? So again, a quote from the Reminders Alone group in which the participants are describing sort of retaining that intermittent use of their use of inhaled steroids. It was not necessary for the reminder because I always took my preventer in the morning and at night whenever I deemed it necessary. My asthma symptoms can go away for a month at a time, so with no issues, I didn't see the point in taking it in that period. I'm sure this is very common to all of you. And in the reminders and discussion group, participants described a change from this intermittent behavior into more regular medication taking. If I didn't take part in the study, I'd probably be the same as before. Take my preventer for a couple of weeks, put it away, and that's it. So I'm grateful to the study, to be honest, because it has put me in the routine to regularly have to take the medication. I like the way she says, have to. Maybe that's revealing. So I just wanted to acknowledge the NHMRC who funded the study, the patients and GPs who participated, and the Sydney area divisions of general practice who helped very much with recruiting GPs for the study, my co-authors, and also importantly, the many research assistants who helped us make this happen. Thank you so much.
Thank you, Juliet. That was fantastic. It's always a tough ask to be presenting late in the day when we've had so many good speakers, and you've done exceedingly well. It just shows that meaningful engagement with consumers does yield really positive results, and we've seen that from both case studies that we've heard about this afternoon. We've got a couple of minutes before the final session of the day. Are there any questions in the room for Juliet?
You can ask me something silly, it doesn't matter. Go on then.
Are there any devices like that on the market?
Yeah, at the moment they are still research devices. These are made by Nexus 6 in Auckland in New Zealand actually, and they have talked about whether or not they'd be at some point available to patients, and certainly quite a number of the participants I interviewed said things like, oh, the one participant who had, which ringtone was it? Benny Hill, called it Pinky. There must have been a ringtone to do with Pinky. She befriended it so much and she hated giving it back. But of course there were opposite reactions too, and some people found them really irritating. So you had people saying, it was really irritating, I hated it, I couldn't wait for the study to be over. But others saying, it was really irritating, it made me do it, and now I can see why you need a preventer. So there was a real sort of just taking on and understanding through that learning process of seeing that it worked. They stuck with it because of the reminder. So I think that didn't answer your question, but hopefully in the future they will be available. They're about $180 at the moment, and the people I interviewed said they would, I think the range was they would pay, this wasn't in the interview protocol, but I just asked at random, they would pay somewhere between $15 and $100, $15 and $100. So I think it's still a bit too pricey at the moment for consumers to actually buy them, but yeah.
Okay, Juliet, thank you very much. It was all good. Well done.